I'm Heather, I'm one of the medicine nurses. I absolutely adore medicine, I will talk about it all the time. But today we're going to start with sort of a brief overview of learning with lymphoma. I always say when people ask me what is medicine, I say we are the detectives. So today with the medicine portion, we're going to be putting on our detective hats and working through a case. So we are starting with a patient that has presented to us. It is a dog. They have presented for lethargy, inappetence or anorexia. We've got to say 4 or 5 days at this point. Weight loss, pyrexia, and we're going to think what are our next steps to getting a diagnosis. So we are going to start with a physical exam. Highly recommend every nurse that any patient that gets admitted, you do the physical exam as well as your vets. So we start with a temperature, pulse, heart rate, respiration rate, mucous membranes, capillary refill times. We do this all the time. Physical exams as well, make sure you're going from nose to tail and really getting a hands-on feel on all your patients. We do rounds every morning of all of our patients, and there are often times the clinicians will ask us, have we noticed any abnormalities? So really get a feel for, is there any lumps and bumps? Is there any, anything that you find odd? Is there something wrong with our TPR? We also then do a body condition score and muscle score. For our patient today, we've got weight loss. So it's really important that we do our body condition score and muscle scores because we need to know where this weight loss has occurred from. Is it from the muscles or is it from the body? So in our physical exam, we have noticed that our patient has a temperature of 39.3, and we've also felt that there's a left submandibular and right popliteal lymph node enlargement. So, what would be our next step? We are going to do some diagnostic tests. We always in medicine are the vampires. We love biochemistry and hematology, and that really does tell us a lot of the baselines if there's nothing abnormal, or if there are some abnormalities, we can really point them out. We may be doing some 3-view chest radiographs and abdo ultrasounds, or we may do a CT. Now this is very dependent on sort of the size of the dog. If you've got a massive Great Dane or a big Bernese Mountain Dog, an ultrasound is not going to be your friend, and you're not going to have happy clinicians or vets. So we would do CT in those, and probably a bicavitary imagery. We are also going to take some fine needle aspirates for anything that is abnormal. So those enlarged lymph nodes, we're probably going to be taking FNAs on and sending them over. The liver, spleen, really important diagnosis for lymphoma. It really kind of helps stage where you are with your patient and what sort of stage they've got on, but we'll go through that later. And any other abnormalities seen on ultrasound or CT. We are going to potentially do flow cytometry. There is a slide on that in a minute. And for gastrointestinal signs, we may be looking at endoscopy, which I love about, and if anybody wants to talk about endoscopy, we'll talk about afterwards. So, flow cytometry, what is that? So, basically, flow cytometry is a really fancy way to say that we are just going to type what our blood is doing. So it's called immunophenotyping, and it's basically assigning a lineage. It sounds very sort of big and fancy, it's not. So basically, when somebody comes into practice and says, oh, this is a T-cell lymphoma, they've done flow cytometry to figure that out. So there's T and B cell lymphocytes, and these are assessed on flow cytometry. It's also used to evaluate the cell complexity, size, and the expression of multiple leukocyte antigens. Basically, it is a tool that is used alongside diagnosing of lymphoma, and it is critical for the prognosis, because if a lot of carers come to us and say, what is the likelihood of this patient going on for years and years and years, we need to know all of this information for flow cytometry to understand that. However, it is not a standalone test. You need to have it alongside your FNAs. So, how do we carry out flow cytometry? Basically, we collect 1 ml of EDTA from our patient, we spin that EDTA down and separate the plasma from the blood. We also add 0.5 mils of saline into our plasma, and then we obtain off FNAs of any of those enlarged lymph nodes and blood if there's nothing there. And we place the aspirates into the little EDTA that we've created. So we repeat this 2 to 3 times, sometimes in different sites, because that gives us more information, and then we send it off to the lab. Now, it is really important that our samples are only viable for 48 hours. So if you're doing this test on a Saturday, I don't recommend it. You're going to be repeating it on a Monday. So, going back to our sort of diagnostics, why would we use ultrasound and why would we use CT? Ultrasound, we often do under conscious or sedation, and sometimes with the really good patients, we do it under sort of a mild sedation, and not many drugs are needed. We use sound waves instead of X-rays, so there's no risk of exposure. It is more widely available in practices. How many people have ultrasounds here? Great. It's also effective for assessing the size, shape, layering of your different organs. So highly recommend having a look at whenever there's the GI tract. When you're looking at intestines, you can see the layering really pretty on an ultrasound. It is difficult in our large dogs or deep-chested dogs, as said previously, and it is usually less expensive. So that compared to CT, well, we usually use general anaesthesia in our CTs. We really need to make sure that our patients are still. So often a general anaesthesia, and especially as we're assessing the chest and abdomen, we ideally want no movement. So causing apnea, for example, we can do that under a controlled situation where our patients are under GA, compared to if they're just under sedation or they're conscious. It is more expensive and it is only available in sort of more specialised or advanced veterinary centres. How many people have CTs here? Oh, nice, couple, good. You do get more detailed images and better visualisation of certain structures that you may not be able to see in ultrasound. And unfortunately it does use X-rays, so there is a risk of radiation, so it is worth noting as well. So let's have a look at some ultrasound images. Here we have an enlarged lymph node that's next to the liver. This one is 0.689 centimetres. It really does vary. Apologies. It really does vary on what a big lymph node looks like, but usually if you can see it, it's not good. So that one is a one next to the liver. We've also got a really nice intestinal iliac lymph node as well. So you can see just above is where the intestines are, and then the lymph node is just sitting underneath. And then we also have a jejunal lymph node, which looks really abnormal. So as you can see in the others, or hopefully you can see, they're usually a nice round shape. This one is round in shape, but there's definitely multi-cavities happening in there. So we definitely want to sample that one compared to CT. So this is less of what you can see on a CT. Here are the hepatic lymph nodes, these two little blobs that are on there. But it's more to say that what you're going to be doing is going in with your ultrasound probe here, and in your big deep-chested dogs, trying to reach up into there and get your hepatic lymph nodes. You're not going to see that much. So you really want to ensure on your big dogs that you're using the CT so that you can see everything that's going on. So, shock horror, our patient has been diagnosed with lymphoma. So lymphoma is the malignant proliferation of lymphocytes, which are a major component in the immune system. However, what most carers would like to know is what are the remission times and the lifespan after diagnosis. And really, we can't give a set answer. We really can't, because of we need to know sort of the type, the location, the stage, and also the patient itself. If we're going for sort of treatments, it's really how are the patient's going to respond to chemotherapy, if that's what they would like. So, talked about stages of lymphoma. There are 5 different stages, and each one of them gets a little bit more severe the longer on with the list we go. So stage 1 is there's only one lymph node involved. Stage 2, we have multiple lymph nodes, but they are all one side of the diaphragm. So they're either chest and up or abdomen and below. Stage 3, we've got multiple lymph nodes included, but they are both sides of the diaphragm. Stage 4 is any of the above, but with our liver or spleen involvement. So that's where really FNAing that liver and spleen helps with your staging, because if there's liver and spleen involvement, you're looking at stage 4 already. And stage 5, really not good. This is where your bone marrow, central nervous system, and or other extranodal sites are affected. So once we're hitting stage 5, we're really on end of life care as much as possible. And there's also substages. So substage A, there's no clinical signs. Substage B, you've got clinical signs. So going back to our patient, we have enlarged left submandibular lymph node, enlarged right popliteal lymph node. We also have the enlarged iliac and jejunal lymph node. However, we have a normal liver and spleen, pyrexia, weight loss, and inappetence. So, what stage would we put our patient in? And I will just give you back the stages so that you can all have a little think. So, we're stage 3B lymphoma. So from that, we can make a diagnosis, we can work alongside oncology and figure out a plan, which is where I will pass you on to Emma.
Thank you, Heather. My name is Emma. I'm also one of the internal medicine nurses, although today we'll be talking to you about nursing an oncology patient. So as we've learned from Heather, lymphoma is the cancer of the lymphocytes, and because the lymphocytes have access to the entire body and they circulate freely around our body, this makes lymphoma a systemic disease. Combination therapy is the best strategy for us to achieve the longest disease-free intervals. Many patients successfully achieve remission, although unfortunately relapse will occur at some point. CHOP protocol is our gold standard treatment, and it comprises of both orally administered drugs such as prednisolone and cyclophosphamide, but also intravenously administered drugs such as vincristine and doxorubicin. There are other options in case our CHOP protocol fails, and these drugs would be tanavir, lomustine, and chlorambucil. So the side effects most commonly seen are gastrointestinal upset, and that would be vomiting and diarrhea, although let's not forget that anemia and neutropenia are also quite common. A lot of the intravenously administered chemotherapy drugs we use are potent vesicants, so if we do administer them perivascularly, the risk of extravasation can be quite severe. It's always important to know when we use these drugs what our extravasation protocol is, and if we do have an antidote that we can give. So usually with zinc ankylosing drugs, we recommend heat packs to help distribute the drug along the leg that we've used, whereas with drugs such as doxorubicin, we normally recommend ice packs to prevent the drug dispersing any further, and we can also administer an antidote IV as well. So what can we do to try and reduce as much as possible the chances of error and mistakes? Here at the Ralph, we do like to use checklists for a variety of purposes and procedures. And when used effectively, checklists should be read in front of everybody involved in the procedure, and every single bullet point should be ticked and marked complete before we move on and to something else. So what sort of things do we normally have? So I don't know if you can see the checklist from the end of the room, but we'll go over some of the points anyway. So checking blood parameters. So before giving chemotherapy, our clinicians will probably want to double check things such as hematology, and PCV total solids, and we're looking at neutrophil counts and platelets most commonly. Some of our patients will need pre-chemotherapy drugs such as meropetant to help with nausea, so it's always important that we make sure that if our patient needs it, then we've given it. Confirming intravenous access, so making sure that the IV we've placed is safe to use, so a clean stick IV to avoid as much as possible the risk of extravasation. Double checking the drug dose. I guess a mistake that can be easily made, mistaking mg per kg for mg per square meter, but it can have some really severe side effects, so it's definitely something that we should do is get someone to check our calculations. And same with selecting the correct drugs. Vincristine, vinblastine, similar name, but it can have quite severe consequences if we get them mixed up. Confirming route of administration. Certain drugs can be given intravenously, certain ones can be given orally, and some will be given subcutaneously. So it's important that we know which drugs we're using and how we're giving them, because the effect can be slightly different. Being familiar with the closed system transfer device that we're using to make sure it's set up appropriately and we're not going to have leakage halfway through administering an intravenous bolus. Confirming that everywhere is wearing the appropriate PPE, and we'll get to a little bit later discuss what is classed as appropriate PPE, and similarly with the spill kits, making sure we have them available, and we'll discuss a little bit later what should be in our spill kits. And finally, making sure the room is set up and appropriate. Ideally, you want to use a room that's fairly quiet, has a door that you can keep the door closed, locked even, avoid foot traffic and distractions. So now we've checklisted, we have other patient-related considerations that we should keep in mind. So we've got temperament. We can have really bouncy patients, we can have really anxious patients. So it'd be good to have a conversation with our clinicians about potential drugs that we can use. We like to often use gabapentin and trazodone to try and settle them a little bit, make it safer for them and make our life a little bit easier as well. Challenging IV access, quite common with our frequent flyer patients. They're going to have probably thickened veins, scarred veins, they're going to be difficult to cannulate. Keeping record of which vein we use can be really useful. So on each patient's record, let's write down what vein we used, perhaps even why. And it can help us next time they come in so that we know, let's avoid this leg, it was really scarred, the back leg worked really well, let's stick with that one, avoid poking them, prodding them too much. Medial and lateral saphenous veins, I feel we most commonly go for cephalics, but perhaps we've got a nevus patient, doesn't really like us being up in his face, let's opt for a back leg whilst one of our colleagues happily feeds them away. Lots of treats, lots of snacks as a little distraction. And let's not forget jugular sticks as well. So if our patient is coming in just for a blood test, or if we're doing a blood test before deciding how we're going ahead with chemotherapy, let's use the jugular vein and preserve the legs for catheters only. What we like to do as well is train and teach our carers to apply enema cream at home. So it's something that us nurses can definitely get involved with. We'll clip the legs anyway most of the time, so then send them home with a tube of Emla-Cream, a little bit of vet wrap, and they can apply it before the appointment, and it can help with our wriggly patients. So now we've got, we checklisted and our patient is settled, he's got a patent IV. What are the key points to consider when administering chemotherapy? So we want to make sure our patient is comfortable and well restrained. We don't want them to be up and touring the room whilst we chase after them with an injectable. But we also want whoever's restraining our patient to be comfortable as well. So obviously, if our handler isn't settled and constantly repositioning, then it's going to cause our patient to be wriggly and unsettled as well. We want to make sure to only flush the IVs with 0.9% saline. Heparinized fluids and Hartmann's can cause some of the chemotherapy agents to precipitate, so we really don't want that to happen. We need to monitor for signs of extravasations whilst we administer the drug, so any sign of redness around the IV site, the patient reacting, wanting to pull in their leg back. They're not usually signs that we get when the IV is safe and patent, so it's definitely something to look out for. Administer over an absorbent pad, just for safety, in case we do have a little leakage. It's easy to spot and it's much easier to contain if it's being absorbed into like an incontinence pad or something like that. And when administering the chemotherapy, especially intravenously, regularly draw back on the syringe until you see a little flush of blood in your T connector, and that's just a nice visual reminder that your IV is positioned correctly and it's still patent and it's safe to use. Once you're done administering the chemotherapy, then connect another syringe of flush, but this time flush it all through without drawing back, and that's just to make sure that you don't have any chemotherapy agent left in your T connector or in your IV. So once that's done, you can safely go ahead and remove the IV, so try and have a pressure bandage ready at hand. And when you're removing the tip of the catheter from the patient, just do it nice and slowly to make sure that the tip doesn't flick back in the air and spray chemotherapy drug all over the room. You can then dispose of all the equipment, so ideally have a sharp cytotoxic container, but also a leak-proof cytotoxic bag available. And once that's all disposed of, you can go ahead and take off your PPE. So I apologise in advance. The next few slides are sadly going to be health and safety related. I know it's not the most exciting topic, but it's definitely something that needs to be covered. I will try and keep it as short and sweet as possible, and hopefully you'll be able to take some useful tips home with you at the end of the day. So let's start with health and safety around the hospital. So ideally try and have this patient easily recognised. You can use a different coloured harness, a lead, a collar, a bandana, whatever you have at hand. And that's just so that when you're walking your patient along the hospital, you don't get stopped by every single member of staff for a cuddle and a smoosh, because your patient is cytotoxic and you need to be wearing gloves when you're handling them. Similarly, if we have a label or a laminate on their kennel, it can indicate what drug they've had and how long they'll be cytotoxic for, and that can be useful for anyone that will be having any sort of interaction with them, even if there's no one else in the room to alert them to the fact that they're cytotoxic. Wards nurses, nursing assistants, whoever will be dealing with that patient, need to be aware on what PPE they need to use and when. So when you're handling the patient, always wear gloves, but if you're cleaning up with the kennel and there's any bodily fluids, then ideally they should be wearing goggles and a face mask as well to protect against any sprays. It can be useful to have chemotherapy waste bags just outside the kennel, so that any soil, any equipment that's been used can be disposed of straight away and safely. And similarly, you can have dissolvable laundry bags available as well, so that any bedding can be put in there and kept separate from everything else. So you've got then a little chart of how long the patient is cytotoxic for. So examples, cyclophosphamide is 4 days, doxorubicin is 7 days, vincristine 3 days, chlorambucil 2 days, and lomustine 3 days. So what about health and safety for those directly involved in administering and handling these drugs? So your practice should definitely have protocols put in place. But normally what we say is open vials should be stored separately in individual Ziploc bags, nicely labelled with what the drug is, and ideally discard date as well. No food and drink should be allowed in any area used for chemotherapy, and that's for personal, obviously, health and safety. Laminar flow hoods are recommended for drawing up and dispensing any chemotherapy drug, but obviously if that's not something that your practice has available, or you don't have the space for it, then you can order preloaded syringes from quite a lot of suppliers. Using a closed system transfer device is essential to avoid spillages or leaks whilst administering the medication. It's good for anyone that uses them to be aware of how they're set up correctly, how they should look like once they're set up, and be familiar with using them. So spill kits that we discussed earlier should contain at least one set of full PPE. they should have some absorbent material that can be used to clear up any liquid spillages, but also some moistened absorbent material that we can use in case of like a powdery dry spillage. We should have a scoop or some forceps in case of any sharp objects, and again, waste containers. So a chemotherapy sharps box, but also a leak-proof bag. PPE wise, very important, nitrile gloves should be worn. Latex gloves do not offer the correct protection. Face masks with respirators, surgical face masks again do not offer quite the right degree of protection. Long sleeves, impermeable gowns, and I'd like to stress the word impermeable, because if you're just wearing a normal gown or a lab coat and you have a liquid spillage, then that can easily seep through and get to your skin, so that's not good enough. And safety goggles, and that's even if you already wear glasses, again, the level of protection is not quite there, so safety goggles should be worn. And we have a nice example here of one of our chemotherapy nurses, Christine. As you can see, she's wearing full PPE. Our patient Minnie is nice and settled. She's got a nice padded bed. She's got an incontinence pad in case of spillage. She's being restrained, but not heavily restrained. And you can just see at the bottom, Christine has a little tray, and that's where we normally put our equipment once we've used it, before we get to pop it in a waste bag. So we've made it through most of health and safety, which is an achievement. So now let's move on to health and safety for the carers, and this is something that nurses can really get involved with. We've got the patient, we've got the time, we've got the knowledge and the skills to be having these conversations with our carers. So if we can try and give them peace of mind and make them feel as comfortable as possible, then let's do that. So who should not handle cytotoxic medication waste? Young children, immunosuppressed people, and pregnant women. Trained carers to administer oral meds, so gloves should always be worn, and ideally let's only choose to do this if we know that our patient is going to take this oral medication. So if we know we've got a difficult patient, then this might not be the best option. Wear gloves, like I said, when handling body fluids, so when cleaning up after a patient, be it our cat's litter tray or our dog's feces, let's wear gloves and double bag all these bodily fluids. It can be useful to restrict toileting to a designated area of the garden. If we've got children, if we've got multiple pets, let's keep our oncology patient urinating maybe in a separate part so that we can restrict access. Avoid toileting in public areas where children play. You'd think it's common sense once you've read it, but it's maybe not something that you would have thought about. If our patient has an accident outside on hard flooring, then we can use dilute bleach to rinse it off, as this is known to denature the drug. Ideally, let's not use a hose pipe because of the splashback that it can cause, but one of our carers had a brilliant idea, and she has a designated watering can that she uses that she can gently pour over, and we really like that idea. We recommend it a lot. And similarly, if the accident happens indoors on hard flooring, we can use any sort of disinfectant that we would have in the house, but again, to avoid splashback, let's remove the spray nozzle and let's just pour it on top instead. Okay, so that I think wasn't too bad, heavy but not too heavy. To end the presentation, I thought we could go over some frequently asked questions that we get from carers. Again, I've said this a few times already, but it's definitely something nurses should be involved with. We get lots of emails, lots of phone calls from carers, and why not let the nurses answer them? So will my pet go bald? No. Some terriers and poodles may see that their fur grows a little bit patchy. Fur does tend to grow a little bit more slowly once they're on this treatment. And cats sometimes tend to lose their whiskers, but otherwise no, your patient will not go completely bald. Can I still touch my pet? Yes, absolutely. Ideally, wash your hands as much as possible after you've had a cuddle with them, and discourage them from licking you, especially your face. Should I change my pet's diet? no, we don't usually recommend this as long as our patient is eating well and is happy on that diet. What we do say is ideally don't feed your pet a raw diet, just because when they're not feeling great, their neutrophil counts are low, they're more prone at picking up infections, so it's not probably the best option. And I know someone who had chemo and had major side effects. Is vomiting not normal for someone on chemo treatment? Well, it might be for humans, but in pets, because of their life expectancy is not quite as long, the drug doses we use are more aimed at managing and containing the symptoms that they are at targeting the cancer itself. So no, vomiting is not common, and we really should encourage our carers to let us know if they're seeing any vomiting or diarrhea, because the chances are there's definitely something we can do about that. So that's it, that gets us to the end. This is a nice picture of Minnie, the patient we met a little bit earlier on, with her certificate of completion after finishing her chemotherapy course.